a project that aims to identify patient-generated priorities within consumer research. So I'm a researcher here at Simon Fraser University, and most of the research I do is around primary healthcare. But actually, my expertise is in quantitative research methods and using administrative data within the province of BC to look at changes in care and changes in policy. I'm also fairly new in my career, but early in my career. And so this project emerged from a period of time where I was thinking about what might be next for my own research and trying to think about how to involve patients constructively in what I was going to tackle next in my work, but try to make it also a little bit relevant for folks, for other people and other researchers within the province. So that's where I was coming from. And Brenda came on a few months into the process. So just, do you want to provide a little bit about you and where you're at?
I came on, I was one of the responders to the request for patient partners through the Patient Voices Network. And so we came on, the members of the Patient Advisory came on through that. So the project was sort of already up and started. Our first big sort of involvement was the brainstorming and the teleconference with the experiences that we had had in primary health care. So that was the big start. We were involved in the questionnaires, and then since that we have been looking at ongoing priorities for where this might go next. There's also a number of us that have taken a great interest in providing patient feedback on early stages of grant reviews for researchers. So that was something that was sort of very interesting and you know, a bonus that we got to do that.
But a bit about you, you've got a wealth of other roles with respect to patient involvement in research and in different capacities. So she jumped straight into her role on this team, which was enormous, but this is just one of the roles that Brenda's been involved in over your
Yes, I have been on a variety of different things. I'm particularly interested in ethics, for example, and so I've done various things with patient-oriented research.
So great to have you with me today. I'm going to do a lot of the talking and then turn to Brenda to check in at various points throughout the presentation.
You need to be a bit more in the screen, in the camera.
So the plan for what we're going to do today is I'm going to provide my really quick introduction to primary care without making any assumptions about, just to make sure we're all defining things in the same way. And then I'm going to touch in on some of those other roles within the Primary Care Research Network Patient Advisory that Brenda had talked about. So that's the broader group that took on this work, and then zero in on the priorities for research project itself. It's going to be a pretty high-level overview of the process and what some of our take-home messages might be for future research. Brenda's going to offer some perspective on the process as a patient partner, and our thoughts sort of about what might be relevant from this process for other areas of research, maybe outside of primary care. So I show this slide a lot when I'm presenting because primary care, if it's working well, should be an inviting front door for our healthcare system. It should be where patients can go and know that they can get the care they need or be directed to care if needed elsewhere, which can't be provided within the primary care setting. And if all was working well, it should also be a place where patients can go and have relationship-based care if they choose that, and have someone who knows their story and can help navigate throughout the health system. So within British Columbia, primary care could look like a few different things. For many of us, in the top right-hand corner, it's sort of a family doctor's office, where we have a relationship over time. Mid-Maine's an example of a community health center where people might be able to meet with a team of providers based within a community. But for many within British Columbia, primary care could take the form of a walk-in clinic like is shown within the superstore in the top left, or they might reach out to the emergency department for primary care services. So the thing that's really, I think, important about primary care from the perspective of patient-oriented research, and that I think a lot about as a researcher, is it has to meet the needs of everyone. We all use primary care at some point, but our needs and our perspectives on what's important for primary care could differ a lot depending on where we're coming from. So primary care, it's for everyone, and what does that mean for setting priorities? I wasn't quite sure. Well, a place to start seemed like getting together a bunch of people who might have different perspectives on primary care. So as I said, I was trying to think of where I wanted to be going within my research, and I spoke to Sabrina Wong, who's the director of the British Columbia Primary Healthcare Research Network. And there was an identified need within the network to involve patients in a number of different activities. So Brenda had mentioned providing feedback on grant applications, providing feedback on the network itself, but it also seemed like a great opportunity to join forces and take on this question of what should priorities be for primary care research going forward. So we put out a call through Patient Voices Network and through other relationships we had, and tried to bring together a group of 10 patients who came from everywhere, every health authority within the province, who had different needs for healthcare, ranging from sort of one-off episodic primary care when something comes up to people who had long-standing chronic conditions, people with visible and invisible needs for healthcare, and who came from different backgrounds with respect to ethnicity and languages spoken. So this is the group of 10 of us that started off the project, but that I also want to acknowledge had these other roles within the network, as you had mentioned. So this is a photo from the first time we actually all got together in person. So throughout this presentation, all credit to this patient advisory who really spearheaded the PREFeR project and also contributed to primary care research in these other ways. But again, one of our top orders of business was to come up with a structured way where we could identify patient priorities for primary care research. Again, since primary care is where we go for most health needs, and ideally it should have this element of continuous and relationship-based care. It affects everyone. And as a researcher, I often think that my research is addressing patient needs and gaps in care. But when we looked around, we couldn't find any examples of where patients were included in prioritizing research ideas in a structured way. So there are other examples of processes that had been used. So James Blend's Alliance obviously has really a well-developed model. We were informed by the dialogue model, which might mean some things to some of the researchers in the room, but we haven't seen examples of it applied within the space of primary care. So we set out to do just that. As context, we had a list of existing priorities within the Primary Healthcare Research Network that had been developed in consultation with policymakers and researchers and some clinicians involved as well. And as you can see, they're very broad priorities for primary care research province-wide, but patients hadn't been part of that process. So you show up to a meeting and our agenda is to identify patient-generated priorities. One of the things we were curious in doing was comparing how patients and primary health care providers differed in what they thought was important from that list. And then we were curious how the priorities we identified through this process compared to those existing priorities that I showed you on the previous slide, and that are available on the website if you want to read through in greater detail. But that all of this was intended to come up with some top priorities that could inform future projects. So we come together as an advisory, we're meeting in person. What are we taking on? This is an overview of all of the stages within the PREFeR project, and we're going to go through each in some more detail. The first task that
it was our first homework assignment.
Your first homework assignment was?
We were asked to go away and brainstorm, think about and note what stood out for us in primary care that we would like to comment on or share that we thought was relevant to setting priorities. All of us went away and did that individually, and then we sent that into the researchers and followed that up by a teleconference to discuss it after they'd had a chance to sort of, I guess, try to organize the themes that came out.
And from a researcher perspective, we'd spent some time thinking, what's the right question to ask? And so we came up with what stands out for you, because we didn't want it to push results positively or negatively. Just simply, what are experiences that you've had that might inform where we go for research? So there was that initial brainstorming. We came together, we discussed topics. Then we moved through a series of online surveys and a couple other checks to scan the environment for what else was out there with respect to research, and we'll explain all of these in detail. And now we're at the final stage of getting the word out there and disseminating results. So you'll see this sequence come back again throughout the presentation. Anything?
No, I think
launch into it?
Not sure.
Okay, so these first 4 tasks, brainstorming what stands out, and then bringing those together to identify some priorities. We asked you to do your homework. You went away, and as a group of 10 patients came back with over 80 experiences and examples to share on a teleconference call. As researchers then, we took a first stab at grouping those into topic areas and brought those back to the patients within an in-person meeting. And do you want to fill in on what happened during that day?
Sure. I think that with the teleconference, we sort of had a working concept of the topics that we were talking about. Our first meeting, actually, of meeting each other in person and meeting the researchers in person, was a group meeting that was fairly early in the process. A lot of material tried to cover that day, and an amazing amount of things and suggestions came up that it would have been lovely to have the time to go into, but it basically was a very rich discussion. When we were sitting down and talking, the researchers fortunately had sort of a guideline of how they wanted to work to narrow down the top 10 topics. And so for us, it was a lot of discussion of what we saw or what we were thinking of by the 18 topics that we started with. We found that there was times that we needed to spend a bit of time sort of trying to define or specify exactly what we were meaning, because something might sound similar but actually be meaning something rather different in terms of the examples that we were thinking of. So the definition, I think we ended up with some time on that, just figuring out what specifically we were meaning.
Absolutely. So for those 10 topics, much of the day was spent coming up with some text that all the patients could agree on that summarized the experiences that had been grouped together. So some examples are shown here: care guided by patient needs, values, preferences, and priorities, or information sharing, including electronic medical records. And below are examples of the experiences that had come from the patient. So all of the language in the end was supplied by the patient advisory, and the labels are, like the text in blue, was developed by consensus among the patients. And then, so the full list of 10 you can see here, arranged in a circle, because at this stage there was no order or ranking. We just wanted 10 topics that we could move forward for the next stage of the project. But I think it's worth pausing to go through that. So at the top of the wheel, guided by patients' needs, values, preferences, and priorities, seen on the previous slide. The idea of improving and strengthening communication between patients and providers. A related idea, but separate, around information sharing and including electronic medical records and the technologies to support information sharing. The idea of access to primary care providers. So here, that idea of being able to find a regular provider of care who's willing to take you on, which is similar but a little different from the idea of what can you actually get care where and when you might need it. So some patients within the group could access care through a walk-in clinic but didn't have a regular provider, or some patients had a regular provider but found it tricky to get into care.
And that was actually an example of where we needed to sort of discuss it and discover there was actually 2 key thoughts in there, which is that having a primary care provider was one thing, and then everything else we meant by access really fell under another group. So that was an example of our discussions.
Moving on around, the idea of support for living with chronic conditions and the unique resources needed to be in place in the context of a long-standing illness. So jump in if I'm missing anything. The idea of support for mental health resources within primary care emerged within this initial topic setting, and we'll talk a little bit more about it later. So obviously it's an example of a chronic condition, but the consensus was that resources for mental health needed to be a topic of its own. Challenges that may be unique to small towns and cities or remote areas of the province. New models of primary care that include other healthcare professionals. So this is a bit of a standalone in that it spoke to sort of policy changes and organization of the delivery system, but again, there was consensus it needed to have its own topic area. Yeah. And then finally, that idea of improving continuity and coordination, which again would be related to the care needed for living with chronic conditions, but deserves its own topic area. Anything I'm missing or that you'd add? I
just add that a lot of examples that came up in terms of improving continuity and coordination were people feeling that we were not necessarily the best people to be trying to give the details of what, for example, a specialist or a physiotherapist had recommended to a primary care provider, and that it seemed that maybe there was unnecessary vagueness or difficulties in having patients do that, and that having that be part of the system, that information went directly from one healthcare provider to another was a big part of coordination of care.
So those were our 10 topics to carry forward. And the next stage that we planned were 2 online surveys, one to reach out to other patients within the province and one to reach out to primary care providers within the province. So I think you summarized it nicely that
we, in a different sense, we were involved in that. What happened was after the priority setting workshop, the researchers sort of took that away and worked with it, and then developed the outline for the survey. And then as that was coming up, we reviewed it again, talked about how people might interpret the wording. Is there a clearer way to say that? We did sample, sort of a dry run. If we were filling this out, can we work our way through it? So in that sense, we gave some feedback as well there in terms of the...
So there was actually kind of a shift, whereas for the first stage, I think we designed the process to elicit the topics sort of as researchers and participants, but I think moving forward, it was really, we were all sort of taking this on as a team in developing the survey. So I won't provide a lot of detail on the methods for the survey, but really happy to fill that in if it's of interest during questions. So there were 2 parts to the surveys of patients and primary care providers, rating the topics on a 5-point scale from not at all important to very important. So we didn't ask people to put them in order. We just asked them to assign a rating, and all could be rated as very important or not at all important. And we collected some socio-demographic information to get a sense of who was replying to the survey. We changed the order so that wouldn't affect the ratings in case people assigned higher priority to things that they encountered first. And we got the word out entirely through social media, some e-newsletters within organizations we had relationships to, snowballing, where we asked people to forward along the link if they had participated in it. We had a study website, and so all of that was online. The one thing we did to try to reach out to folks who might not have access online was place some ads in local newspapers, mostly in smaller communities outside the Lower Mainland, to try to oversample in an area where we were concerned about getting responses. We provided the option to respond online or by telephone, but we actually only had one request for a telephone survey. So data collection proceeded through the spring of 2018. And in the end, we had 460 respondents. from all over the province. In fact, so this map just shows the percentage of respondents. Clearly, we have higher population within Vancouver and Vancouver Coastal and Fraser, so we were actually surprised to have more respondents than would be expected based on the population in the interior, the North and Vancouver Islands. So great representation throughout the provinces. Because we'd asked those questions about socio-demographic information, we could compare people who replied to our survey to people who replied to the Canadian Community Health Survey within British Columbia. We did find that people who replied to our survey were younger on average. The 79% were female, so predominantly female. Most had some post-secondary education or a university degree. And a slightly higher proportion rented. So just to highlight some of those key differences that we wanted to reach out broadly, but that doesn't mean that the people who replied to the survey were strictly representative of the whole population. And this is the order of the ratings that patients provided. So I want to call attention to the fact that the mean ratings on average were all between important and very important. So none of the topics were
less than important
on average. Yeah. And we're going to go through in another slide that more clearly shows this rating. If you want more information, the mean ratings were here. We went about anything I'm forgetting about the survey process?
No, I think I would just note that there was a smaller response. A lot of people who didn't fill it in. There was some people left out the one about challenges in small towns and cities and remote areas, which I took to mean that they didn't want to say it wasn't important, but perhaps felt that they didn't have the familiarity to comment on it.
Absolutely, an important point. On the provider side, we received over 170 surveys back, which is way more than we'd expected. We were a little bit surprised, though. In BC, there hasn't been a lot of support for providers other than general practitioners in delivering primary care, just in terms of allocation of funding. So roughly half were family physicians or general practitioners, but we also had a number of nurses and other allied health providers identifying as primary care providers and responding to the survey as well. Here again, the 3/4 were female, and we did ask some questions about the types of practice that people were involved in. Of note, we also had very good distribution in that more than expected respondents from rural and remote practice locations.
And maybe could you just comment on how our sex distribution compares with the general response?
Right, so we don't actually have data on what the gender breakdown would be across all of these different service providers.
And then in terms of females tending to be the respondent in research studies.
Yeah, that is consistent with expectations, but that we can't claim to have accessed all folks who might need primary care in a consistent way. So again, here the mean topic ratings from providers. But this will probably make more sense in this figure. So apologies that the text is quite small, but what this attempts to do is to show those ratings from patients on the left-hand side of the screen and providers all in one screen. So what I want to draw your attention to is, again, the range here in terms of mean ratings is from 4 to 5, so all fairly important on average. Ratings from providers were slightly lower on average than in patients, but that could just be how people interpret research questions. And that, in fact, the alignment was pretty, that these corresponded pretty closely. Both identified being unable to find a regular GP or other primary care providers, that idea of accessing a place of care, as the top priority. And that topic around mental health resources within primary care came next on the list for providers and was also next on the list, clustered with some other priorities for patients. So on average, pretty good alignment. Anything else you would add on this figure?
I guess just the interesting fact that for patients, second place was essentially a three-way tie, and that there sort of was more of a difference that the top two priorities for the providers, there was a drop in the general importance after that, whereas there wasn't as much of a sort of clumping with the patients, although there was, I mean, there's three at the end that were clearly lower than the others.
Yeah, that in both cases there was front runners and then three that received lower priority on average, but again, still rated important. So to summarize there, patient and providers agreed on a lot, that the top rated priorities were consistent and included being able to find a regular place of care, mental health resources, and then followed by information sharing. And when we compared these to that previous list of priorities that are still on the website for the Primary Healthcare Research Network, they're pretty similar. Like you could line them up, but with two exceptions: that idea that mental health resources within primary care stood out on its own, and the idea of improving the communication between patients and providers hadn't been previously identified in the priorities in the works. So that takes us through to the providers. We had a couple other bits of the project that I want to mention. We did do a series of very rapid literature reviews, so using just a single database, Medline, and just over the past 10 years, we developed searches for each of the 10 topic areas and then put limits on to search just within British Columbia and Canada-wide. And credit to undergraduate students here at SFU who took on that work. And here we found that there's much less research within primary care just within British Columbia than in Canada. And that there were some areas, especially that sort of access to primary care providers piece, that where there's not much out there so far. However, all of this would be limited by how we constructed the search terms, that this was just a quick look, but definitely work to be done. We also reached out to researchers to ask, what are you working on now that we might not have captured within the literature review? And heard back from 9 researchers, which is, again, probably not bad, given that not a lot of us are working in this space. And that aligned actually quite well with the published literature, with not a lot in the works around being able to find a regular doctor or other provider, and that point around accessing care where and when folks need it. So work to be done. A final piece was to bring together patients and providers in person in a dialogue event. So this is after the surveys had been done, and our hope here was to get some help interpreting the survey results from patients who were on the advisory, but we also invited a larger group of patients with, again, trying to find folks who have different experiences of care, as well as primary care providers. And I think as a research team, when we were reviewing the results, we were struck by that things seemed to align quite well between the patients and providers, and that was the consensus, that differences were minimal within the room, and that all priorities seemed quite important. But what struck me were some interesting differences in interpretation of the topic areas. So one thing that stood out for me was around electronic medical records, where patients were speaking to the need to be able to access their own medical record, whereas providers were speaking to sort of the ease of use and functionality of the EMR, and perhaps expressing some hesitation at patients being able to access the medical record for themselves. I think you had some other examples of where...
Yeah, elements of patient-provider communication. Again, we saw things differently, and also we were tending to define things differently sometimes. It really came up in the dialogue that there was sort of 2 elements, or even 3 elements of that. One being patients were feeling frustrated, needing to retell a story again and again, but it came out the providers were saying, well, we need that to confirm your diagnosis. So that was something that was sort of a particular thing that patients had found frustrating, which was actually needed to give proper health care. But something that did come out as well was the providers said, well, maybe we need to keep in mind that we might not be as well understood as we were hoping that we were, and that, you know, just in the communication with the patients in terms of them understanding what they're supposed to do, or did they get their most important questions asked, that was actually a separate thing that needed to be addressed within communication, so that it was actually sort of broad. And when the providers thought of it, the first thing they thought was, well, I need to hear the story again and again to make sure that this diagnosis is correct. And a lot, I think, from the patient perspective was, well, did I completely understand that, or I'm not quite sure, or I'm trying to remember what my specialist told me to fill in my GP. So we did mean things slightly differently there. The other one that was very interesting was the issue of accessing care where and when patients need it. We're talking minute differences, but it was one where there was a little bit more of difference between the provider's response and the patient's response. One thing that to me came out as as thinking of the patient's perspective is, I think that the providers were only able to see what passed in front of them, so that they probably only observed accessing care where and when patients needed it to be a problem to the extent that it caused somebody to end up in a worse condition or in the hospital or something like that. Whereas there were probably a lot of difficulties that didn't come to providers' attention if somebody is worried all week because their kid is sick and they actually couldn't get time off work to take them into the doctor, or if they couldn't afford to not work, one day to go in, or just issues like that, that may actually be valid barriers for patients, but they wouldn't necessarily be something that providers are aware of because they don't even know that this person had trouble and would have come in but didn't, or that they were maybe, up all night worrying about their child. So that is, it seemed to me that actually sort of talking about defining the issues further, and being a bit more specific about what each group contributing ideas is able to see, and also what we're not seeing. That to me came up as something very interesting from the dialogue that wouldn't have happened if we didn't have that shared experience with patients and providers.
So as from my perspective as a researcher, I was quite surprised, in fact, at how well the priorities aligned across groups. This maybe shouldn't have been all that surprising, in that these are quite broad areas. They're broad topic areas, and as you've described, there's a lot of unpacking to do in terms of exactly which elements are we focusing on. But that the patient perspectives provided through that initial discussion of experiences and through that final dialogue event at a depth and I think really necessary context to the topic areas. So, for example, on the topic of rural and remote settings, really focusing not just on the location of services, but on transportation needs, and how privacy or stigma might play out in rural settings with more limited providers available, for example. I'm someone who does do work in the area of workforce planning and how many physicians do we have, how many primary care providers do we need. And this came up as a topic, but framed differently, framed around that point of accessing someone to provide care as opposed to sort of workforce planning or health human resources as we describe it within the research literature. So I think that was enormously helpful. I do think there are some points that we need to keep in mind. This was well, maybe not all that quick, but a relatively quick exercise to try to identify very broad topics. And while providers were involved at the dialogue event and in rating the topics, they were not part of that initial brainstorming. So this is a really big difference from some of the priority setting processes that have been used elsewhere. We deliberately focused on patients from the start, and these really are patient priorities, not the results of a dialogue. As I've shown you within the numbers, that the survey respondents are not likely to be representative of the province as a whole. They're probably representative of people who feel strongly enough about primary care to complete a survey. And in many ways, the advisory members themselves had more diversity with respect to some of the characteristics that might shape primary care use than survey respondents. And again, this point that these are not research questions that we identified. They're broad topic areas that could be identified into research questions, and that our hope, as you sort of identified in the case of communication, is that patients and other voices would be a part of that process. So I think so I can talk more about how we're carrying this forward, but a number of considerations for future research, the ratings of topic importance, but also the fact that there was strong alignment between patient and providers, and some evidence that the existing research doesn't align, we think should all inform future research. But also that in some areas the topics might point to the need for strengthened knowledge translation or implementation science to make changes in service delivery, and that not all are necessarily topics where a whole lot more information is needed to act. So that's, I think, some take-home messages from the process itself. And I'm going to turn it over to Brenda to offer some reflections. If there's anything I
add
missed,
on the dialogue very quickly, I wanted to add that one thing I think did come up for the patients was not only accessing a regular GP, not only an issue of is there a body, but is that body accepting patients with the conditions that I have? There was very much a sense that people with more complex conditions, complex chronic conditions, multiple conditions, were finding it harder, much harder than the average person to have a GP take them on. So I think that, that was an example that I think is fairly important, because the issue of number of providers doesn't necessarily address that. And the other one that came up very strongly for me from the dialogue event was the interesting difference in that the patients tended to value very highly quality of life issues, which I think was very related to feeling a desire for greater support for chronic conditions, whereas the providers were sort of thinking, well, we've done it, we've managed it, we were keeping an eye on it. So that it seemed to me that in actually having the patients feel supported, it was something that to answer this and make people feel happy about it, that there was actually going to be a need to define what we're meaning by this and what quality of life issues are affected, and perhaps even just informing providers. Maybe providers don't know the range of quality of life issues that may be affected for people with chronic conditions. So that was just things that I found came up from the dialogue that, again, I don't think would have without everybody being involved.
Absolutely. And very happy to discuss the priorities themselves and what they could mean for research if there are questions. In the next couple slides, Brenda had just prepared some observations about the process itself that could be relevant to other research groups. And I think then we'll have hopefully lots of time for questions. So I'll turn it over to you for the last couple pieces, and then hopefully we can have a conversation.
Yeah. Okay. One thing that I think this was a very positive experience for all patient partners, and not always being the case. It was asked, could we think of some of the things that made it work well, or that we would suggest for other people to look at. Respect was a really major foundation of it. Basically, I think that certainly the patients felt respected. Hopefully the researchers felt respected too. And I think that was a real foundation of any kind of a true partnership. Consideration is also really key, and I think because this is still in sort of a new area, people are feeling it out. In somebody being a patient, there is probably inherent symptoms or challenges that are involved, certainly by the time you're looking towards chronic conditions or multiple conditions. So people may have, difficulties that they are trying to overcome in being involved as partners, and just being aware of that. The other thing is a bit of a social issue. Our society tends to assume that every difficulty is visible. It's not. People think that challenges are visible, black and white. They're yes or no. The reality is they're often chronic and fluctuating, people may be, like, I, could do more that week than I can this week. They're often invisible. So I really think I would suggest going forward that it's really necessary to not assume that, patients may not be trying to overcome extra difficulties that might not have been considered. So I think any kind of thinking ahead of time about how can we make sure that we're at least aware of, problems that people may have so that we can try to work around them is a really big thing. Don't assume, would be my big statement there. Flexibility is another huge thing in terms of consideration. The patients are in different circumstances. Some people may be unable to work, and probably if they could be, working 9 to 5, they probably would be. So if those people are trying to participate in partnerships, they are probably, going through a great amount of effort to be there. Other people, maybe they are working, and not everybody's job is such that they are going to have the freedom to take time off during the day to do something, or, they might not be able to have any flexibility in their job hours at all. So I think, again, just knowing that going in and planning how, one thing that seems to me is inherently a part of patient partnership is that it's not a 9 to 5 thing, and it needs to be figured out how to handle it. In PREFeR, a great example was the use of teleconferencing. That made things incredibly more accessible, I feel, for a lot of people. Both the geographical problems, but also it was just easier for people because, it was one less barrier to overcome. So that kind of forethought, I think, is important. Yes, what came up is that a lot of times, as we were discussing, there was a lot of thoughts or suggestions or points that would come up that were maybe not directly related to the specific research question that was being asked, but seemed to be something that could be of value in the future, or either for future research or even to other researchers, just points that did come up as patient input when you had patients together discussing that. And I thought that if there was some kind of a plan to note out-of-scope discussion points, that's almost sort of a byproduct of patient partnership research, and that it is probably worth keeping that, because even if it's not useful to that researcher, it might be useful to a researcher down the road. Again, I guess the other thing is just being sensitive that patients have different backgrounds. Some of them are going to have a reasonable knowledge of research and how it proceeds, and others are not. So trying to sort of help people understand how that process works is helpful, I think. And yeah, so what really, I would say, made a difference is, first of all, there was just an incredible amount of respect. That we really did feel respected and valued as partners, coming together with the researchers to try to work on something that we all felt was important. It was really key that patient ideas were given equal consideration. There was never a feeling that it made a difference if an idea was suggested by a patient or a researcher. There was really a strong sense that everything that was brought up was evaluated based on merit. So it did not on who said it. Again, this lets people sort of buy in and feel that we were part of it, and we really felt like full partners throughout, start to finish, or at least start of when we came in. That, again, there was a sense that we are working together with the researchers. We all think it's important. We're coming together because we think we can do better by working together than not working together. A big issue is that sometimes in patient partnerships in research, some patients end up feeling that they were sort of tokens, that lip service was paid to patient partnership, but they were just sort of there at the table because somebody had said, oh, you better have a patient there. And that is something that patients have tended to feel frustrated about, or has tended to make it not satisfying experience for them because we didn't feel tokenized. We did feel that, the researchers felt that there was something the patients had to offer and that, our ideas were being given equal consideration. The fact of not being token partners, but being actual partners was really, really a big issue, right? And also just knowing the fact that we got a little bit of an explanation of the background and the fact of the, where the primary healthcare research network is fitting in. There's a little bit more of an understanding. We didn't feel that we're going to come and put thought and time into this project and then it'll be over and we'll never know what happened and we'll never know if anybody even listened to it. I think because there was a little bit of trouble taken to try to help us understand how this fit in to where the province was trying to go, where the research network was trying to go, that really helped us feel that, oh, okay, there is a reason for doing this. It's not just going to disappear into thin air once we're finished. So that all of those I think were important for having patients feel really good about the partnership experience.
Well, and there were only a couple of us researchers within the mix of 10 patients, so I think strength and
they were surrounded.
So I really do want some time for questions. So just to reflect on this, that it was absolutely feasible. It was a totally fruitful process, but that in fact there were more similarities than differences in what we identified, and that I think where the benefit really came in some of the richness of interpretation around the different topic areas, and that every one of those elements could itself spark a really important research question and a research project moving forward. So I really do want to acknowledge the patient advisories. The support unit provided in-kind support through training, help with the survey dissemination, and was an invaluable platform for this work. I want to acknowledge other co-investigators who contributed to this project in early stages and are supporting dissemination. And thanks for money from the Center for Health Services and Policy Research and CIHR patient-oriented grants. So, anything else?
I think
okay.
We had such a rich experience. We could talk forever, but we will let people ask questions, I think.
So now we will see if I can effectively use this platform. But yeah, if there are any questions, please let us know.
Yeah, so thanks both to Ruth and Brenda. Great presentation. So we have a lot of participants on the line right now, so feel free to, if you can see the hand beside your name, it's right beside the little red microphone. You can raise that, but if that doesn't work, feel free to unmute your mic or, again, use the chat function. And
a question from Colleen, what's next? So I can speak to that very briefly. So we are in the process of getting results out there, and that's taking a number of different forms. So the dialogue events brought together patients and providers, but it also had a piece that I didn't mention around bringing together researchers and policymakers to see how some of the questions align with policy directions within British Columbia and within current strategic priorities within the primary healthcare research network. So I think there's a higher level conversation about priorities within the network and what might be supported there. But at a more granular level, the priorities I have taken off into, I think we have 2 project grants under review now with patients on the team that respond directly in the areas of mental health services and care guided by patients' needs and priorities. I'm leading a big grant in the area of access to primary care providers and workforce planning. So there's sort of the high level what's next, and then the work that a number of other individual researchers are taking on and trying to respond to priorities in one way or another. In some cases, that's been sort of refining an existing project idea that to better align with the patient-identified priorities, and others, it's been sort of a whole new research idea that this is something we really wanted to take on, I think especially in the area of mental health.
That was a big one that
yeah,
came up. It wasn't identified previously, and especially since everything is talking about how mental health is hopefully going to be handled in primary care with all primary care providers' free time. I think that was a big issue. The other thing is I think it's probably relevant that we are trying to, meet and figure out where the advisory can be constructive, how can we, where can we go, what worked well that we'd like to keep going.
Yep. I will admit that our timing wasn't perfect and that many of the SPORE opportunities responded to the priorities that I listed that were within the network, but we hadn't done our work yet to align that. So it was reassuring that things aligned well. And this doesn't feed directly into new SPORE applications, but I think the fact that then these are being carried forward in existing funded grants within the project scheme process sort of speaks to some of the sustainability.
You also haven't got the phone call saying, and I think you should research this too yet. That may happen, right? I think that I seem to remember giving you a couple of homework suggestions. It would be so valuable if you would also do this. So, I think that hopefully all of us are still thinking about what can we do useful for this. I think there was so much that, certainly from the patient partner perspective, there was so much I learned and so much that we ventured into that I didn't necessarily realize at the beginning, that it sort of becomes a richer and broader field the more we participate and learn about it. And I think all of us are trying to figure out, okay, what are ways that we can keep the Primary Healthcare Research Network Patient Advisory being active and useful going forward.
Absolutely. So I just did a quick check to look for any of those raised hands, and seeing none and no other questions within the chat box. Oh.
I just wanted to check in with Pat Atherton. Pat, any comments, questions, thoughts?
Thank you so much, BC Support Unit, and thank you so much, Ruth and Brenda, for this excellent presentation. I've been just glued to all of the details of your project here. I've been hearing about PREFeR for a while, and it's been great to actually get the drilled down content. I know that No, not at all. I found it fascinating. I especially like the alignment of the patient and provider slide. That was fascinating. So thank you so much on behalf of the BC Support Unit for your contribution today.
Another question within the comments. So could you please elaborate on something you noted around not a whole lot more information is needed to act? What solutions came out, maybe referring to action? So one example I think is around the topic area around the like team-based models of primary care, for example. That there's been some research in BC. There's a wealth of research in other contexts that supports efficiency. It supports better experiences for patients and better experiences for providers to be able to work as a team. So that's an area where maybe the answer is not a whole lot more research about should we have team-based care, but what would that look like to implement within the British Columbia setting? So that's my comments around where it might be more of an implementation science or a knowledge translation question as opposed to a whole lot more original research, for an example. Does that make sense?
I think that makes sense. I was just going to add sort of the rather amusing fact that I think there was so much that came out useful about patient partnerships that we actually discovered that there was no way we could possibly fit all we had learned about patient partnerships and what made for effective partnership with researchers in our very short presentation at the BC Support Unit. So I thought that was just sort of amusing. We learned so much that we couldn't tell you all. So that, again, really, I think not only the research, but the fact of working together and how to work together effectively, I think was something very important that happened during this project.
Okay, I realize we're running short on time, but I'm just keeping an eye on the comments. So in terms of questions around the alignment within the current integrated system of person-centered primary and community care policy direction, so lots of activity within the province right now with respect to primary care networks, with respect to patient medical homes. And so, Claire, I think that's a great question.
Yeah.
I think in the spirit, there's a lot that aligns. I think the question will be, how does that play out? And whether there's the evaluation to know that that it sort of truly is addressing some of the topic areas herein.
And if I could just jump in, I think number one, integrated is definitely there's a brief similarity between the integrated care from the Ministry of Health and the idea of coordination that were expressed in the patient priorities. And I think a lot of the person-centered, patient-centered care issues, I think in order to have patient-centered care, you have to, number one, be listening to the patient, and number two, that you have to, if these are priorities that are important to patients on the whole, then in order to have patient-centered care offered, I'd say by definition, these need to be considered in being managed. So I would say that, yes, I think that there is quite a strong connection, because I would say, like, I think that the model of integrated patient medical home, I would say, must include managing these questions and, improving issues here to do a good job. That would be sort of my feeling of how they're related.
Sums it up. Okay.
So I think that brings us to the end of the questions and the end of the discussion. A big thank you to both of you guys for joining us, and for everyone who joined us online and participated in the discussion. Our next webinar series is on January 30th, if you guys can join or are interested. Thanks very much.
We good? Thanks so much.
Hi, Cleon. Hi, Gail. I'm seeing names I know.
Okay. Sign off there. Thanks so much. It's been a terrific opportunity. Thanks for providing this platform.
Yes,
Great.
thank you very much.